people so far. I think we've got about 40 people so far, and the numbers are building. So good afternoon, everybody. My name is Jim Gooden and I'm Vice Chairperson of Mental Health Foundation Australia. I'm your host for today's webinar. I'd like to begin by acknowledging the Wurundjeri Woi-wurrung people as the traditional custodians of the land on which I live and work, and pay my respects to them, their culture and their elders past and present. On behalf of the Mental Health Foundation Australia and the CEO, Mr. Vasant Srinivasan, I would like to welcome and thank each one of you for attending today's Be Well educational webinar on understanding problem anxiety. Build your working model. Now I'd like to introduce our presenter, Dr. Christopher Mogan. Dr. Mogan, I know very, very well from many, many years, and he's a great supporter of the Mental Health Foundation. And we're very fortunate that for many, many years, he's donated his services and his expertise to us at the Mental Health Foundation. Chris is the director of the Anxiety and OCD Clinic in Richmond, in Melbourne. He is a graduate of the University of Melbourne with honours and a master's degree in psychology, graduate diploma in mental health sciences, clinical hypnosis, and a PhD in the Department of Psychiatry and Psychology. Specialises in anxiety and related disorders, including panic and worry, social anxiety disorders, phobias and avoidance, post-traumatic stress disorder, obsessive compulsive disorder, hoarding, disorders. And I know that hoarding disorders are a particular interest of Chris's at the moment. He was the clinical director of the Anxiety Depression CBT program at the Melbourne Clinic from 1987 to 2007. Over a 20-year period, he developed a specialised CBT, cognitive behavioural therapy treatment in this acute inpatient psychiatric hospital, and established a range of day programs for anxiety disorders. Dr. Mogan and consultant psychiatrist, Dr. Scott Blair West, also founded the inpatient group treatment program for patients with severe OCD, obsessive compulsive disorder, that continues to be Australia's only group inpatient treatment, CBT treatment for OCD. Chris, great to see you again, and please, everyone, join me in welcoming Dr. Chris Mogan.
Thank you, Jim. Well, thank you for inviting me again to speak to the Mental Health Foundation's Be Well seminar. Anxiety is indeed a part of our lives, and today we're going to focus on problem anxiety. I'll just go to the next slide. Thank you, Mattia. So when we have problem anxiety, normal anxiety is something that is just part of our lives, part of us staying alive, part of us being able to adapt to changed conditions. But when we reach problem anxiety, it's because it's triggered too easily. It lasts too long, and it reaches high intensity. So those kinds of things like confused thinking, overwhelming feelings, and avoidance and disruptive behaviours, these are what we call problem anxiety, because they interfere with a person's functioning. They combine with other conditions to disrupt the person's life. So anxiety can be part of an anxiety and depressive mode, or anxiety can pair with OCD, and anxiety can also be expressed in post-traumatic stress. So each person, when they come into our care, we try to identify the key triggers that might set them off into a state of anxiety. Now, those triggers will just say, for example, a person has a fear of a dog, just as an example. The next stage of our development would be, what is your self-talk in regard to the presence or the proximity of a dog? The person would say, I'm worried the dog will attack me. I'm worried the dog will, I'm fearful of being bitten. And the third step along the way is to ask what sort of behaviours would follow that appraisal. And sometimes these behaviours become ritualistic or avoidant. So in the case of that example, a person would ignore anything else except getting away from that dog. So the person might cross the road, or the person may go into a panic state. But the main thing is they never want to see a dog or touch a dog. And if they don't, they can have a normal level of anxiety. But when they see the dog, the phobic anxiety sets in, bringing uncertainty and tension and a high trauma load, because every time they see that dog, they will be petrified in that way. Now, we can describe anxiety in many different ways, such as social anxiety, post-traumatic stress, panic, generalized anxiety. But the main way that we want to talk about it here is that it's just a state of arousal that has interfered with the person's functioning. So over a long period of time, a person may build up a high level of sensitization to whatever people, situations, thoughts and feelings. And when they are in that state, they might develop some ways to reduce that anxiety. Now, what we say about that is, if you're experiencing anxiety, we want you to accept that. We want you to try and sit with it, but to get on with your own day. But if you develop methods of, say, reducing that anxiety, those methods can become fixed and repeated, and they're really gimmicks. They do not help with managing anxiety. Now, to illustrate that in the case of OCD, a person may be fearful or worried about whether they will get to sleep. They are worried about, what if I don't fall to sleep tonight? I've got a huge day on tomorrow. And they might develop a particular gimmick, such as doing exercises before they go to sleep. Or they may learn a ritual of touching certain items in their room, lowering the blind to a particular level. And unless they do those things, they will not be able to sleep. It's a gimmick that actually prevents the management of the anxiety. Most of all, in the case of what I've just described, that model of anxiety building over a whole lot of different life experiences can reach a point where the person is overwhelmed by anxiety. Now, we used to use the term a nervous breakdown. Now, that refers to a state of emotional exhaustion. And when we are in such a state, we can experience an unbelievable array of symptoms, from stomach pains to dizziness, to confused thinking, to racing heart, to gut problems. We're unable to function normally because this array of symptoms is bewildering and very fearful. Next slide, thank you. I want to also refer to why some people are going to experience more anxiety than others. And back in the 60s and 70s, a theory of attachment was developed by Bowlby and Ainsworth. And that, I need the next slide. Yep. And this helps us to kind of get a bit of a measure on whether or not where attachments are secure. If I feel that I'm okay and I feel that other people are okay, we can establish a connection between the two people. But if my attachments have been affected by negative experiences during infancy, if they have been affected by disorganized parenting, such as a person who is meant to be the source of love and attachment becomes a source of punishment and rejection, this disorganized attachment is seen by many thinkers as being the basis of psychopathology. And the internal working model that starts from infancy is going to lead to developmental and personal styles that are fraught with anxiety, avoidance, tension, and reactivity. What we can think about is the traumatized child will be vulnerable for the rest of their lives unless there is some form of intervention. Anxiety just doesn't go away. Anxiety has to be dealt with in a working model that brings about increased sense of security, increased sense of recognition, strong identity, and risk-taking, being prepared to take life on. Next slide, thanks. Now, I just want to take a different angle on dealing with anxiety. These modes of anxiety were explained to me when I was listening to a friend of mine doing a webinar in the United States. His name is Alec Pollard. And Alec is a very experienced psychologist and has written many articles and books on anxiety. And he developed this modes of anxiety, which I think are very accessible for people. And a person can say, the first level, these are kind of like, they're not exclusive. You can include parts of them in each of the group. So I know what I'm afraid of. For example, a person may be afraid of making a speech or crossing a bridge. If you know what you're afraid of, that in the case of walking across the bridge, if I go on that bridge, I'll lose control. What if the bridge collapses? I cannot possibly walk across that unstable looking bridge. Now, what we can do with that is by graded exposure, we can test that fear. And graded exposure is a step-by-step manner whereby we coach a person to gradually reduce their anxiety. The second one is, I know what I fear, but what I don't know is when it'll happen or if it'll happen. Is it going to happen in the future? What if this? What if that? The underpinning of this type of anxiety is uncertainty. And this is probably the most striking feature of anxiety, problem anxiety. If someone is running late, they're not just running late, they've had an accident. The person thinks that catastrophic way. that if something is not perfectly taking place, it means it's a disaster. So the uncertainty principle in anxiety is something that is part of life. And we just have to, as we know, we're not even certain what's going to happen in the next 15 minutes. Hopefully, nothing untoward will happen. But the point is, we can't know. We don't know what's going to happen. And that's part of being a human being, to have the confidence to deal with whatever eventuality might turn up. The third type of anxiety is the feeling itself. I don't know what I'm fearing, but I just can't stand being anxious. And we can develop such an oversensitivity to anxiety that we don't want any anxiety. Whereas we know the normal expression of anxiety is to be a protective thing, to heighten our performance, to have a certain level of anxiety. But this particular mode we're describing here is I just can't stand the yuck feeling, the feeling of disgust, the jarring feeling that anxiety brings, or indeed I just find when I walk into a room or come into a particular situation, it's not just right. And if it's not just right, I've got to avoid it. Next slide, thanks. Now here we have an example of what happens in a sudden onset of anxiety. Say the example I'm giving here is seeing a spider, and our anxiety level is going to shoot up. And what reaction will be to get out of there fast. And when we do that, the anxiety will go down because we've avoided any encounter with the spider. But if we can encourage people that anxiety is an emotion, and over time, an emotion does pass. If we have an emotion like humor or laughter, it passes quickly, just as anger passes. Any emotion will pass. So in this particular situation, we're asking a person to create a pause, stay and observe, and over time, that anxiety will reduce, it will fade. And let's have a look at the next slide and I'll illustrate that more so. You can see this is the process of habituation, that progressive trials of exposure lead to diminishing anxiety in response to a specific trigger or situation. So the more I sit with it and repeat that, that over time, the anxiety will habituate. So in other words, that is lowering the anxiety to where it's an acceptable level. Now, I'll just stay with this point that when we're looking at trying to work through anxiety, we don't start with the highest levels of anxiety. These are the panic states or the trauma recollections. What we've got to try to do is build up a picture with the patient or the person we're dealing with, whereby we can have them being able to rate their anxiety at a 0 to 3 out of 10. That's low level anxiety. Moderate level anxiety is 4 through to 7, and high anxiety is 8, 9, 10. Now, in that range, you're going from just experiencing anxiety, say, up to 4 or 5 even, where we can still do everything, but we experience the anxiety. But when we get up to, we experience the anxiety as manageable. And sometimes it gets more manageable the more we hang in there. But when the anxiety is getting higher, 6 and 7, we're getting clear symptoms like shaking or perspiring or dry mouth. It's really interfering with our function. And when it gets up to 8, 9, and 10, that's when it's becoming really disabling. Panic states, and anybody that experiences anxiety will remember the first panic attack they've ever had because it's terrifying. Next slide, thanks. I want to say a little bit more about exposure. It's really the basis for managing anxiety. Exposure is facing it, but response prevention is not using the gimmicks, not developing these little ways that we have, which can be as wide as the imagination. So there are some people who develop blinking. There are some people who bite their nails. There are some people who clench. There's some people whose body is tense all over. Now, when we are trying to deal with it, as I mentioned before, we want to help the person to sit with the anxiety trigger in a graded way. So you start with something very simple just to demonstrate the model. But the person is not to use any rituals or gimmicks, not to seek reassurance or stay with me or explain I'll be all right. No using of safety behaviours, which might be now a perfectly reasonable thing to read a book. But if you're reading the book in order to avoid doing your exposure exercise, you're seeking safety. Or and indeed, the worst level of that is total avoidance. Now, so what we're doing here is exposure is facing up, then no gimmicks is response prevention. We're not doing any of those things. Now, we ask people to sit with this anxiety for anything from 2 or 3 minutes up to 15 to 30 minutes, and we grade it, asking them to be a scientist and think, if you can do this, you can say, my anxiety level about this is 5. Now, after 3 minutes, is it still a 5? Or has it gone up, it got worse? Or has it gone down to a 4? And then 3 minutes later, 6 minutes later, 9 minutes later, and then an hour or so later, you get them to rate their anxiety, teaching them that by repeated exposure, the science is that the anxiety will lessen. It has to be graded, repeated, and then we take the next step up and prolong the exposure. And some people find exposure and response prevention very difficult. But we find that if you coach people, encourage people, work with them, and make sure that they're recording their exposures for later review, that they're really getting a sense of managing their anxiety. Next slide. Now, why anxiety comes is that we've got an amazing mind, and we are confronted by many, many thoughts that will pour into our mind. And people have to recognize that our minds have a store of memories, some good memories, some traumatic memories, some worrying memories, some frightening memories. And our minds are such that we are appraising them in a negative way or a positive way or an ambivalent way. We might raise doubts that we might have acted on urges in the past, and we need to go back over that and review it and try and get more clarity. We might worry that we've acted and thought, worry that in the future we'll be a bad person, bad thought, bad mind, bad person, and worry that we'll be wrongly accused of acting on such urges, and we seek a reassurance about that. So evaluating, it's the intrusive, unwanted thoughts that are the most disabling element of anxiety, because it leads to bad mind, bad thought, bad person, and attempts to manage that cause withdrawal and loss of self-esteem and, low functioning. Next one, thank you. I'll just give you an example here of something that comes across our path in treating OCD, which is an anxiety disorder. What if I can't get to sleep without my rituals? So we may try to do an exposure and they're not doing so well, and they think, okay, I've got to get up and do the rituals, get the blind down to the same level, make sure I've locked the door, make sure I've done my exercises, make sure I've prayed or whatever. Now, what if I harm my baby? What if I have a sexual connection with my baby? These are real problems and taboo problems that people find it hard to share, and only share when it's destroying their lives. What if I lose control if I feel any anxiety? And what does it say about me that I have such thoughts? What kind of perverse mind do I have? No one would ever believe that I could be like this. Now, in that situation, we have to say to people, we cannot control the thoughts that come to our mind. And the best example of this is to think of a dream. When we have a dream and we're petrified and shaking and sweating, and we wake up in the morning and we say to somebody, I couldn't sleep, I had this shocking dream. I was just so thrilled when I realized it was a dream. And they say, well, what were you dreaming about? So I don't know. The point about it is it's such a relief that that it's gone and it's not real. And I had an example of my day is full of examples of people whose intrusive, unwanted thoughts are the beginning of just nightmares for them. Like I'm talking about during the day, they can't function. Did I close the door? Or is my dog got out into the street and been run over? Has my house been burgled because I haven't shut the door properly? Or did I not turn off my hair dryer or whatever? So next slide, thanks. So the fearful mind, we've got to recognize is that it doesn't think clearly. And so we've got two sides of anxiety that are creating problems. One is that we have a store of defense systems that are keeping us alive. This is a non-conscious state that our mind recognizes that the dangers are in our environment. Like sometimes you might step out onto the road and suddenly pull yourself back without any consciousness that there's a speeding motorbike just misses you. But your mind, peripheral vision, set that defense into mode. Now, we have in our brain this series of non-conscious defense mechanisms that store our experiences. They're built into us. Some of them are unresolved and they still cause neurotransmitters to be discharged. Now, what happens then is that a person feels the anxiety, but their mind puts a narrative on that anxiety, which is not necessarily true. So in other words, there is a state of anxiety. Now, one of our famous GPs in Australia was Dr. Claire Weeks, and she had a beautiful model for understanding this. And what her understanding was that any adverse event is stored in memory. And then this has been confirmed by neuroscience, that when we get new knowledge, it's stored in memory. And the way it's, the metaphor that we use, perhaps based on the computer, but the computer was based on the mind, is that there are circuits, trillions of circuits in our mind, which predict our behaviours. So a person might feel in the presence of an unwanted thought, I know I would never do this stuff. And then the doubt comes in, do I really know? I'm losing control. I can't think clearly. I've got to battle it. I've got to watch out for it. Why am I even thinking about it? As I've said, bad thought, bad mind, bad person. I have to watch myself in this situation because I could easily go completely out of control. So there are two factors in the anxiety. One is our experience, our situations, our past. It's all stored, but the interpretation that we make of it is where the problem really lies, and that's where the resolution lies. Next slide, thank you. I'll just give you an example of a case illustrative of what we've just been saying. This is about a father who was petrified about harming his baby. And even if he had to lift the baby up, he would have to pass the baby across his genitals or put the baby on his lap. This intrusive obsession was, does this connect me sexually with my daughter? Now, this is anxious thinking. It's not normal thinking. It's problem thinking. Maybe I want this. I have to watch myself. Maybe I'm really a pedophile, a monster. I couldn't cope with even the slightest chance of harming her. So the person feels anxiety and guilt and compulsively analyzes and reviews all connections and events, seeks reassurance, hypervigilant in their actions, and the exhausted mind cannot process that what seems so real to them. Now, we have to help a person deal with these things. And following Claire Weeks again, she says that what we've got to try to do is help the person to reduce the intensity of their oversensitivity. They've brought themselves up into a state of mind where they feel bewildered. They can't process an unwanted, strange thought that's totally against their values. But what we've got to try to do is lower that sense of being over-traumatized. And we do that through the methods I've described: facing, accepting, sitting with that anxiety, and letting time pass. Now, it'll pass more quickly if we're able to just get on with our day. Now, that idea of when we have an intrusive, unwanted thought, it's just something out of the blue. It might seem completely opposed to my values, but we can't stop it. And if we do try to say, I'm going to watch for that thought, I'm going to make sure I don't have those thoughts, you're guaranteeing you'll have them. What you've got to do is accept it, let it go through to the keeper, put it on the back burner, but get on with your routine of the day. So you create a pause which allows you to sort of open up other possibilities. One thing is I could sweat on that thought, worry about that thought, and guarantee that thought will come back again. Or you can say, where did that come from? And get on with my day. Now you might not realize that 100% of people have intrusive unwanted thoughts. It's only about 1 or 2% of people that develop OCD. 98% of people are able to say, where did that come from? The thought pops in and it pops out. And we want to be able to say to people that when you're bluffed and when you're overwhelmed and can't think straight, you can't process such a thought that's totally alienating to you, and you can't process it. And it brings on this enormous reviewing, guilt feeling, overwhelmed feeling. You're being bluffed by these intrusive, unwanted thoughts. And we've got to take that step back and open up other possibilities. Next slide, thanks. Now, the downward arrow technique is is sort of a way of pushing back at these thoughts. You can push back at them in a therapy situation. So you're saying in that situation, what you're trying to get to is, what is the core belief that the person has? I'll stay with this model here. Can you see that? I hope it's clear. I can see it clearly on my slide. I could have hurt them sexually in my sleep. I could have sleepwalked. What does that say about you? What does that mean? Only a very bad person and a terrible mother would even have such thoughts. Having the thought makes me think I must have done it. And what makes you think that? What's so bad about that? And what does it say about you? I don't even deserve to be alive. I'm a very horrible and disgusting person. And we're pushing the person to say, well, what does that say? What's going to happen then? Well, these worries will be there for the rest of my life. I'll be sad and miserable forever, and I'm an unworthy fraud. Now that gives us something to work with. That's the core belief. And we can then work on that to try to say, well, you know, would you sort of put yourself up there with Hitler, do you, as being a miserable, horrible person? You try to get the person to realize that those worries are not something we've got any control over. They've just popped in, but equally we can teach them how to let them go and resume, like as Claire Weeks says, once that mind that is overwhelmed and exhausted, like mental exhaustion, nervous breakdown, a person can return to normal functioning. Okay, next slide. Okay, so when you are dealing with an emotional crisis, I like to encourage people to have a sort of cue card or just an exercise that they can go through. And the word in this case is aware. What we want to say to people is accept intrusive unwanted thoughts, but pause. See them as only part of your experience. But they become the singular most important thing to you when they consume your whole mind. But they're only part of you. Now, what we want to do is help the person to watch the level. If it's low, we'll take these steps. If it's moderate, we'll do this. If it's high, okay, you've got to have a crisis or an emergency plan ahead of you. The third thing is you've got to tough it out. You've got to act as if you can handle this. In other words, you've got to be in touch with how you feel, but not overwhelmed by it. Now, we really do this on a daily basis. If you and your partner are having a few words about something, misunderstanding, conflict, yelling at each other, and the doorbell rings. By the time you get to that door, you don't say you don't yell at that person. You are, hi, welcome, good to see you. And by the time you lead the person down the hall, all traces of anger and yelling have disappeared. We're acting as if in order to get control, to be in control. When we're not in control, that's when we're overwhelmed and stressed. But when we can get a sense of control, we can start to get back into the game. Now, then you go back over those three things. Can I accept that intrusive, unwanted thoughts are part of life? Can I see that there's a difference between low, moderate? It's not like a switch that I'm either totally calm or in total panic. No, it's a dimensional thing, and we can have different strategies for the different states. The second point about the letter R is creating a gap, like it's like saying taking the pause. It means opens up the possibility of refocusing on your schedule. Now, the last letter is E. You've got to expect feelings like this to come. Just with anxiety, you've just got to expect the unexpected. But you've got to then trust yourself to say, I don't know whether it's going to happen or not, but if it does happen, I'll adapt. I'm learning the strategies to make sure that I can handle anxiety. Now, the last slide, I think it's the last slide. Yeah, now this is Claire Weeks's mantra that she was an Australian, but she was far better known overseas. And although she died in 1990, her books and tapes are being sold at enormous rates. And she had this model of you must face your fear, you must accept it as part of life, part of your life, but you've got to float with it. Now, floating, anybody that's done any swimming knows that floating is not a passive exercise. There's activity, there's energy, there's resistance. I'm going to float against these fears and worries and doubts and uncertainties. And over time, let time pass. And then we add that point I've just made by creating a pause or a space, or some sort of metaphor of stepping back. You open up new possibilities that you could react in so many different ways. Go towards anxiety to face it, never avoid it, and never use gimmicks to manage it. Okay, I just like to finish on that point, but I did want to refer, before I just want to refer to some questions that have been sent in. Is that okay, Jim? So
yes, absolutely, Chris. Absolutely.
Yep. So I'm on the question here. I'll just go through these questions. People have been kind enough to write in. Can we use tough love methods in treatment? Now, I'm a very wise psychologist. When I was in training at the Children's Hospital many years ago, I do remember one thing that he said, and he said, what we've got to do is we've got to give these children, because the children in the Children's Hospital in those days were inpatients mostly and in there for quite lengthy times. And he used, and it's not rocket science, but he said, we've got to love these young patients, but we've also got to set limits. So this is a question now of tough love ideas are very much in consequential ways, that if you've done something, you've got to learn from the consequences. Now, I think it's important that the relationships that we have, we've got to build up in our children a sense of caring and kindness. And so therefore, we've got to demonstrate care and kindness. We've also got to have a relationship where there's good balance of kindness, well, caring, we care, but we also want to have experiences where there's fun and shared things. So we build our child's life on the experiences that we have with them. And some of those experiences will be of conflict, but some more often we want to have experiences that they learn from and grow through. And the third thing that we want to do is be competent. We've got to be competent as parents, and the children have got to be competent at the stage they are. So if a person does what they say they'll do, that's a competent person. If the person is letting the side down, like not working as part of the family team, it's our job to point that out. So I don't like the word tough love in particular. I prefer this idea of that was incompetent. That was you didn't, as they say in the footy teams these days, you didn't play your role. So your role was to take the garbage out. Your role was to switch your mobile phone off so you're not getting calls at 2 o'clock in the morning and then complaining that you can't sleep or you're too tired to get up and go to school. So I would prefer to put the idea there of, the self-driven child, the competent child, and the shared experience of being a parent and being a child together. Now, is treatment different from people also diagnosed with PTSD? Well, in the case of where you've got two diagnoses, we call two comorbid diagnoses, the diagnosis of the treatment is along the lines of what's primary at the moment. So if you've got a person with, in this particular case, PTSD and OCD, well, if the PTSD is flaring to such an extent that they can't participate in the therapy of that we require, which is hard work in OCD, you treat the primary condition and then treat the others in turn. I hope that answers the question. That obviously anxiety rarely sits alone. It's always got other conditions in play. But if the anxiety is the primary condition, like avoidance, not being able to go to work or go to school, that's got to be the first target. It's the primary target is the most active condition. Now, how can generational anxiety be predicted? Three generations, and the fourth has arrived. What predictive factors and identifiers should be looked for in the young child? Yeah, well, look, there's always a genetic factor in any condition, but it accounts for about 50% of the variance. But it's the environment that the child is raised, where their patterns of attachment that we referred to earlier, also their trauma load is predictable. Because if a child is in a toxic environment where there's violence or unpredictability, or if a parent has got an unmanageable mental illness, those children are going to be guaranteed to be affected by that themselves, because they're not developing the adaptive skills that they need to manage their own experiences of conflict or decision-making or sharing or building confidence, so that our sense of self is very much intrinsic, and it's based on having our needs met, our needs for recognition, our needs for love, our needs for guidance, our needs for encouragement and fun and good experiences. So I don't think that because that there have been 3 or 4 generations of anxious people, that's necessarily going to continue. It's a problem that can be resolved through proper therapy, proper and proper sharing. Now we have this next question is about the education system and children struggling. And look, we've got to say over the last 3 years, we've got to say children, adolescents, university students, people in education, oh, what a shame they've had such a time that they've been robbed of the opportunity to mix together, to enjoy being lectured to by the teachers, and that's all being done in that sort of sterile online way. It's that the thing is that adequate people can adapt, and we've got to try to adapt. But those people who are more vulnerable, they're going to suffer more. So we have to try to make up for the last. Well, we've been anxious all our lives, but the pandemic has made everybody anxious. I mean, you'd be stupid not to be anxious in the case of living through a serious pandemic which has affected the world in every way. So really, the question here, what is the answer? Well, there's an issue here about what the NDIS should be dealing with. Now, like, I would like to make the point that there's no disability more prevalent and more affecting people more than mental illness. And I think that the NDIS is meant to look after people with disabilities, and they need to lift their game in, but it's got to be done. I guess we're $1 trillion in debt, but we still have to make space for those 20% of our community who are suffering from a disability. The point about anxiety, as Claire Weeks points out, is if we can have a model to work on and work at that model, we can reverse the ill effects of anxiety, and people can thrive again. Now, well, there's another question about the NDIS. Well, with regard, it says the specific expressions of anxiety. What's important about them is they're very specific. So a person with social anxiety finds it difficult to be the center of attention, finds it difficult to be assertive, and their progress in any competitive environment is really held back. And they can also be held back in relationships and finding a partner and things like that. GAD is generalized anxiety disorder, which is people who worry about, we all worry, but they worry more than the average bear. And they worry about a lot more topics, so that their time is absorbed by worry. And panic disorder, so those people with panic disorder, these are people that it's not a question of having a panic attack, it's a question of having panic attacks all the time. and such a disabling condition does require both medication and CBT for a good outcome. What's the latest evidence-based treatment suggestions? Well, as I've been pressing here, I believe that psychological methods are crucial absolutely crucial to treat anxiety. Now, other people have responses to medication which they become dependent on it. Other people can use it very sensibly, but it does. I'm just saying, not medication alone. Medication plus talking with people, communicating with people, and not necessarily therapists, but as much as family support, that the family and the relationship group around this person is inclusive. The biggest problem we've got in our society is that people are not inclusive. And there was a beautiful show on TV the other night about the town of Luton. And it was a great example of about 7,000 people and the way they have made the different cultures that have come there feel they are wanted and cared about and really respected was very heartwarming. It's something that we need to do, is to be more inclusive and just that we're all the same. And it's such a pity and a shame that we're treated differently when we're all the same. That's one of the problems. Now, two more questions here. Are there levels and different stages of anxiety? Well, you could say, I mean, I could have taken another stance on it and said there's anticipatory anxiety. What if this happens? If this happens, and what if I don't? What if I blush when I'm speaking or whatever? Then there's moment by moment anxiety. I'm talking with someone, and but I'm worried about, is my voice sounding strained? Am I looking at the clothes I've got on? And there's so many kind of static, so that my communication with that person is interfered with because I'm thinking about all sorts of other things instead of homing in on exactly what that person's saying. A mindful conversation is one where people listen to each other. An anxious person is worried about, did I say the right word? Was that intrusive of me to do that? You know, so, and then the third part of anxiety, a different level of anxiety, is when we replay everything that's happened. But if you're going to replay it in a compassionate way so that you can learn something from it, rather than replaying it, I got that wrong, or that person will never talk to me again, and in a judgmental and tension-creating way. Okay, I've got to race here a bit. Can you have anxiety even on medication? Well, you certainly can. That's why you need to, you need psychology and psychiatry in dealing with a severe problem of anxiety. But even when you're on medication, you know, well, not everybody responds to medication in the same way. In fact, some people, there's probably some 30% of people can't take medication. So it's like, I'm just making the point that medication is not the full answer. It's part of the answer. And so is psychology part of the answer, or therapy is part of the answer. But it's not a simple question of take this and you'll be right. No, take this, but talk about your issues as well. Now, what techniques can a teenager do to help with anxiety, especially regarding schoolwork? Well, I suppose we're running out of time here. I'll just make the point that the teenagers are, it's at a stage where, you know, their self-esteem is very vulnerable. They're very vulnerable in that way. And the schoolwork is needs to be planned or scheduled And that's the best piece of advice I can give, is that we need time for sleep, we need time for fun, but we need time for your work. So in the case of a teenager, their work is going to school and doing homework, but it might also involve, a part-time job as well. But the work task is one of the major issues of passing from being a child to being an adult, is that I've got to learn to take responsibility. I've got to learn to do what I say I'll do, and to repeat the football mantra, I've got to play my role. And in the family and in my personal role, the work task is going to be setting me up for my future if I can be focused on my schoolwork. But many kids need help at that stage. Now, any other questions, Jim or Aura?
I think you've done very, very well, Chris. I think you've covered most of the questions. I don't think there are any others. I can't see any others coming up. Anyway, look, I think we've taken you away from your lunch hour for long enough.
Excellent. Yes. Yeah, you've taken my lunch hour, actually.
Exactly. I think we have to leave you and let you go and have a nibble on a sandwich or something. But I'm just looking at some of the comments from the chat, and you've been extremely helpful to a lot of people today. Some people are saying, "I love to watch this again on replay. Thank you for today. Thank you, Dr. Mogan. Very insightful. Greatly appreciated. Thank you for the most wonderful webinar," etc., etc. So from the people that need it, that's very gratifying. And once again, Mental Health Foundation is indebted to you. Just by the way, people are asking if they can view this again, and you can on our Facebook website, the Mental Health Foundation website, and also on our YouTube channel. This will be available. So all of that really insightful information. Oh, we're getting lots and lots of new messages. Thank you for your time. Clear ways to support others with anxiety. Very informative, great information. Thank you for an excellent presentation. Where are you located, Dr. Mogan? Yeah, so I think you get the message there that you've been extraordinarily helpful. I just find a point, perhaps an existential point that you made there about the underlying reality of life, the human condition, is that it is uncertain, it is unpredictable, and that's the nature of our lives. And somehow we have to develop some sort of personal insights and philosophies that allow us to deal with that and to cope with it. That's a slightly different level from, all the very practical insights and information that you are making, but it's a difficult one, and that's where we enter the spiritual dimensions, if you like, of mental health. Anyway, once again, yes, you were going to say.
I'm just saying thank you, Jim, and I am a great admirer of the work of the Mental Health Foundation of Australia, because the point I made about Leeton, I think your organisation has got an amazing connection with the multicultural community, which is really a model for us all to follow.
Thank you very much for that. And that really is a particular focus of ours, and I'm very glad you reminded everybody who's watching. By the way, we had over 90 participants, well in excess of 90 participants. Just to let people know that we do run an anxiety support group here at 10 Yarra Street, South Yarra. Chris, you must drop down and see us sometime and have a cup of coffee. We'd love to share some nice Turkish lunch with you. My shout if you come over. That anxiety support group is on the third Wednesday of each month at 6 p.m. That's 10 Yarra Street, South Yarra. Our next webinar will be on autism and mental health on the 19th of July at 1 p.m. by Professor Amanda Richdale. So in the meantime, to our watchers, I bid you adieu. And Chris, I look forward to seeing you face to face, hopefully with a nice convivial visit to our little mental health hub here in South Yarra.
Indeed, I'll do that, Jim.
Thank you very much, and thank you,
everyone, and thank
you to our wonderful audience for listening in. You've been really responsive and appreciative. Bye bye, everyone.
Okay, bye bye now.